pancytopenia. Okay, what might the cause of pancytopenia be? Okay, these are the physical signs. These are expected findings. We expect low hemoglobin, low white blood cell, and low platelet counts. What are the diagnoses in this case? Pancytopenia. What causes pancytopenia?
Many causes.
Bone marrow failure.
Bone marrow failure. Excellent. What else?
Anaplastic anemia. Anaplastic anemia.
Well, bone marrow failure, aplastic anemia, they are,
Plastic.
you can use them interchangeably, okay?
Drugs.
What else?
Is it idiopathic?
What can the diagnosis be? So you said aplastic anemia or bone marrow failure, what else? In such a case?
Leukemia?
Leukemia. Is there anything that makes you think it may not be leukemia in this case? Okay, the patient may present with pancytopenia, a leukemic patient may present with pancytopenia, but is there anything that makes you think that it is probably not leukemia?
No lymphadenopathy.
Hmm?
No pain in the bone.
The
Fever.
fever,
Fever.
where if the patient has pancytopenia, why not fever?
No organomegaly.
No organomegaly. You usually have lymphadenopathy, hepatomegaly, splenomegaly, not all of them, but 1, 2, 3 of them in leukemia patients. So we have a case of pancytopenia, and it is bone marrow failure is our topic today. So pancytopenias can be seen with a hypocellular bone marrow or with a cellular bone marrow. Or the bone marrow can be infiltrated by other cells other than bone marrow, other than hematopoietic cells. So if it is a hypocellular bone marrow, the only thing we can think of is, of course, aplastic anemia or bone marrow failure syndrome. You can see a list of these, either acquired or inherited. We will go into details of all these. Or it can be in a cellular bone marrow. In the face of a cellular bone marrow, you still may have pancytopenia, such as it can be primary bone marrow disease, such as a myelodysplasia. It can be secondary systemic disease, such as SLE, or hypersplenism, or vitamin deficiencies, etc., etc., etc. Or it can be due to infiltration of the bone marrow due to some other disorders, such as leukemias or other tumors, okay? Or such as in case of myelofibrosis or osteopetrosis. So what is aplastic anemia? By definition, it is a clinical state where the peripheral blood pancytopenia, so that means there is pancytopenia, resulting from reduced or absent production of the blood cells in the bone marrow. So there is pancytopenia, which is due to absent or reduced production of the bone cells, blood cells in the bone marrow. So aplastic anemias can be acquired or inherited, and there is a reduction in the production of all cell lineages, erythrocytes, platelets, and white blood cells. One, 2, or 3 of all the blood cell lineages can be affected. So that means a patient can present with one cytopenia only or pancytopenia. For example, a patient may present with thrombocytopenia and petechia resulting from this. It may be the only presenting symptom. Or he may come with thrombocytopenia and anemia. or may come with all three lineages affected as pancytopenia. In cases, they may start with one cytopenia, for example, anemia, then it may progress to pancytopenia with time. I told you that it can be acquired or inherited. Acquired can be due to different factors. It can either be idiopathic, which is at the bottom of this table, or it can be secondary to different agents, mainly due to infections, chemical agents, including drugs, infections, or immune attacks, mostly in common. Or it can be inherited. We have a number of inherited bone marrow failure syndromes, which I will go into a bit of with detail of these later in my presentation. So first, let's talk about acquired aplastic anemia. Acquired aplastic anemia can be classified as severe, very severe, or moderate or mild aplastic anemias. How do we define severe? If the lab findings, if the complete blood count findings in the bone marrow cellularity shows at least two of the following, it is considered severe aplastic anemia. Usually, granulocyte count below 500, platelet count below 20,000, absolute reticulocyte count below 40, and bone marrow cellularity between 25%, or hematopoietic elements below 30%. If you pay attention, you may see that there is no criterion for hemoglobin level. Criterion is for reticulocyte count. What does reticulocyte count show? The number of immature red cells. So it is an indirect representation, indirect way of showing the what? Bone marrow activity. So instead of relying on hemoglobin levels, we have a more reliable measures such as reticulocyte count. If it is below a certain level, it is among the criteria for aplastic anemia or severe aplastic anemia. If granulocyte count is less, if it is below 200, it's called very severe aplastic anemia. If these do not fit those criteria, but still the patient's clinical and lab findings are consistent with aplastic anemia, it is considered mild or moderate aplastic anemia. It is not a very common disorder, acquired aplastic anemias, compared with leukemias, for example. It is much less. And there are some risk factors that may cause acquired aplastic anemia. And chemical agents such as pesticides, drugs, or viral agents are the most common causes. But many cases are idiopathic. Well, to how much extent it is idiopathic, we don't know. Idiopathic doesn't mean that it doesn't have any cause. It means it has a cause that we couldn't define yet. We are not able to define it for the time being. Some disorders have been described as idiopathic in the past, but now they have a cause. For example, not related to this topic, but ITP. It was previously named as idiopathic thrombocytopenic purpura. But since we know that it is an immune disorder, it is now called immune thrombocytopenic purpura. So the name changed. So idiopathic definition may change over time. So the causal factors are, as I've told you, can be drugs or other chemicals, in summary, infectious agents or immunological disorders. There are many drugs. I don't want you to memorize all these tables. They are classified as drugs that always regularly produce bone marrow depression, or in most cases. When you look at this table, you can see that most of the agents here are chemotherapeutic agents, anti-cancer agents. So whatever the name is, it usually causes depression of the bone marrow. Actually, this is the reason why they are used in chemotherapy for suppressing the bone marrow in leukemia or other hematopoietic or tumor cells. So most of them are chemotherapeutic agents. Also, there are some antibiotics. Chloramphenicol is one of them, is one of the most well-known of these. Although chloramphenicol is not widely used today, rarely used today, but still you should keep it in mind. But even agents such as daunorubicin, doxorubicin, they are actually, although they are antibiotics by chemical structure, they are used as chemotherapeutic agents. So the way of action is almost the same. In addition to that, benzene and other chemicals containing benzene are important. And these are among the first chemical agents that were recognized to cause aplastic anemia. Workers or industry workers working with benzene or such products were exposed to those agents, had a lot of cases diagnosed with aplastic anemia. There are agents that possibly cause, so insecticides should not be forgotten. Other agents such as anticonvulsants, non-steroid anti-inflammatory drugs, some antiprotozoal drugs such as antimalarial drugs such as quinaprine, chloroquine, and sulfonamides can be considered. And there are some rarely associated agents that may give rise to aplastic anemias. Among the infectious agents, the second group is infectious agents. The most common of these is hepatitis viruses. So hepatitis, you should ask for the presence of hepatitis, for the past history of hepatitis in patients that present to you with aplastic anemia. Other viruses such as Epstein-Barr, cytomegalovirus, herpes virus, and HIV, of course, can cause pancytopenia or aplastic anemia as well. There is a relationship between viral agents, viral disorders, and the drugs. So sometimes it may be confusing. Suppose a patient coming to you with some viral disorder and he has used one of any of the agents that I have mentioned about. So could it be due to the drug that he has used, or is it due to the original infection that he's had? So what is the underlying cause? Is it the aplasia arising from the underlying disorder, or due to the medication used for the disorder? It may be confusing, so you should question, you should take a very detailed history in these cases. As for the pathophysiology of acquired aplastic anemia, we have 4 basic mechanisms. One of them, the first one, is bone marrow toxins. So there are normal hematopoietic stem cells. They are exposed to toxins such as chemotherapeutic agents, or viruses, or irradiation. So this causes suppression of the bone marrow. This is very clear. Second one, there is an underlying abnormality of the hematopoietic stem cells. So they are usually predisposed to hematopoietic stem cell damage. So any slight attack, any slight changes in the environment may cause premature stem cell loss or destruction of hematopoietic stem cells. So there is an underlying abnormality of the existing hematopoietic stem cells. The third one, there is an immune or cellular or immune reaction against those cells. So that may result in aplasia. And the fourth one, the microenvironment, the strong environment where the hematopoietic stem cells sit or reside is not a good environment for them. So there is a problem with the what we call the microenvironment in the hematopoietic, in the bone marrow. So in this cartoon, it is illustrated. And the first one is, as you see, there is normal hematopoietic stem cells, and by a direct attack on the cells, there is such as toxins or other drugs or infections, whatever. There is a destruction of the hematopoietic stem cell. The second one, there is an underlying disorder of the hematopoietic stem cells, and with some stress of the bone marrow, the cells again are destructed. The third one, there is an immune attack. There are antibodies directed against those hematopoietic stem cells, which results in aplastic anemia. And the third one, the cells are okay, they are normal, there is no attack, but the environment they are in is not good. They cannot survive in that environment. So this is the fourth method, fourth way. Coming to immune mechanism, suppose you have a normal stem cell and there is an environmental insult on this red cell, such as viruses, drugs, radiation, whatever. So there is an alteration of these cells. So that alteration leads to expressing new antigens on those stem cells. So with these new antigens expressed, there is a T cell response to those new antigens expressed on the cells. So these are through interferons or tumor necrosis factor. So these T cell responses lead to bone marrow aplasia, bone marrow suppression. On the other hand, again, if there is an alteration in those cells, this alteration also reduces their proliferative capacity of those cells, which eventually leads to aplastic anemia or bone marrow aplasia. All bone marrow progenitor cells can be affected. All in bone marrow, in myeloid, erythroid, megakaryocytic lineages can be affected. So these are all the progenitor cells, such as coloniformic unit granulocyte monophage, in the erythroid cell lineage, coloniformic unit erythroid, or burst-formic unit erythroid. So all these precursors of the cell lineages can be affected by those attacks. So this is a table that I had shared with you previously. So it may be due to hypocellular bone marrow, or in the case of a cellular bone marrow, or it may be due to infiltration of the bone marrow. What is the history when you see a patient with bone marrow failure? Usually the presenting symptoms are due to the cellular elements affected by that disorder. For example, if the platelets are affected, there will be bleeding. If erythrocytes are affected, there will be pallor, there will be anemia. If neutrophils are affected, there will be serious infections. Also, you should ask for a very detailed family history for similar blood disorders, because you may have to differentiate between leukemias or other hematopoietic problems, or even with other systemic disorders such as SLEs or other disorders. And also you should be able to differentiate between malignancies. Developmental history, congenital disorders, metabolic storage diseases should be asked for. Use of medications, presence of infections is a very important part of history for those patients. Environmental history, such as exposure to toxic agents, where the patient is working, what is his occupation, has he been exposed to any chemical agents, such as benzene, or what is in the environment, or some drugs, or there may be a case that they had some fumigation for insects in the home environment. So insecticides can be the cause of such a disorder. So you should take a very detailed history. Do not omit anything in the history. So again, when you go to physical examination, again the findings are related to the underlying, to the cells that are affected. As I have repeatedly told you, if there is thrombocytopenia, there will be bleeding in the form of petechiae, ankylosis, mucosal bleeds from different mucosal areas. If there is neutropenia, you may have oral ulcerations, severe viral or bacterial infections associated with fever, of course. And obviously, if there is anemia, you will have pallor and fatigue, tachycardia, exercise intolerance can be among the findings. Congenital abnormalities for all body systems, all body parts, such as thumbs, extremities, any dystrophic nails, or short stature, special facial features, should direct you to one of the inherited bone marrow failure disorders. Usually, hepatomegaly, splenomegaly, lymphadenopathy are not present in aplastic anemia cases. Lab investigation, of course, there will be pancytopenia or single or dual cytopenia. The anemias are usually macrocytic anemias, neither microcytic, sometimes maybe normocytic. Red cell distribution width is normal. What does it show? RDW. What does it mean is normal?
There's no
anisocytosis.
There is no anisocytosis, so the sizes of all cells are almost the same. There are no big differences between the cells. Reticulocyte count is decreased, of course, and granulocyte counts will be decreased. Peripheral blood smear will show you very valuable information. Bone marrow aspiration or biopsy is mandatory, required to have a very good diagnosis of aplastic anemia, because eventually it is dysfunction of the bone marrow, so you should see the bone marrow of these patients. Also, you should see the bone marrow to differentiate from other disorders such as leukemias or infiltration of the bone marrow with other cells. Of course, if you are suspecting an infectious etiology, tests for infections should be carried out. And if you are suspecting an inherited bone marrow failure, such as Fanconi's aplastic anemia or paroxysmal nocturnal hemoglobinuria, tests for these disorders should also be given. Here you see some pictures of peripheral blood. The one in the top middle is a normal one. So here you see normal red cells and the clumps of platelets, which is the expected. You should also see neutrophils and lymphocytes in the peripheral blood smear. But when you look at the one on the right-hand side, what can you see? Coming to erythrocytes, what are specific about erythrocytes here?
Hypochromic.
Hypochromic erythrocytes.
May happen, may not happen. Usually they may be normocytic. There may not be hypochromia, but you may see. But what is more striking here and in the two other pictures, there are no neutrophils. If all the areas that you scan under the microscope are like these, because looking at only one small area may not be sufficient, you should scan all the areas under the microscope. If all the areas are like these, if there are no neutrophils, almost no platelets, then you can say, well, this looks like neutropenia and thrombocytopenia, which should be confirmed by the complete blood count, of course. And coming to bone marrow, on the left-hand side, you see the healthy bone marrow, full with cellular elements. But the one on the right-hand side, there are almost no cellular elements. Usually it is mostly lipid vacuoles. Here again, on the left-hand side, a normal bone marrow. On the right-hand side, there is a plastic bone marrow. Again, on the left-hand side, there is normal bone marrow. And here, you see the variability of the cellular elements. There are different types of precursor cells. I don't like you cannot identify those cells, of course, at this level, but do you see different types of cells? In the aplastic bone marrow, there are almost no cells, very few cells. But here on the middle one, almost all cells are the same, uniform. These are all lymphoblasts. So this is very typical of acute leukemias, acute lymphoblastic leukemia. So instead of having a high number of precursor cells and variability of cells, in leukemia it is uniformly packed, single type of cells, all blastic cells. Coming to inherited bone marrow failure syndromes, these are genetic disorders, and they are also associated with inadequate blood cell production. Again, here they can present as single cytopenia, or with pancytopenia, or with dual cytopenias. What is important here is other organs or other organ systems may be affected, and you will see a multitude of congenital defects in those patients, in those children. And in addition to those physical findings, bone marrow failure will be associated, but bone marrow failure may not be evident at birth. It may be found, it may be presenting after the age of 4, 5, 6, 7 years of age. Even in some cases of inherited bone marrow failures, the aplastic anemia, the anemia or bone marrow aplasia can be seen even in the adulthood. Although we call them inherited bone marrow failure syndrome, and most of them are inherited, there may of course be some new mutations, which we call de novo mutations, which may be the first case in the family. Some of them are characterized by predisposition to malignancies, especially hematopoietic malignancies. Incidence is higher than acquired aplastic anemias. It is 40 to 65 per million of live births. Here you see a list of the major inherited bone marrow failure syndromes. At the top is the most common of them, Fanconi's aplastic anemia. You can see most of them are inherited in autosomal recessive mode, but there are some inherited as X-linked or autosomal dominant way. Most of them are associated with pancytopenia, but some of them may start with neutropenia. For example, Schwachman-Diamond syndrome, the presenting sign may be neutropenia. It is the most striking feature, but by time it may proceed to pancytopenia. Similarly, Pearson bone marrow pancreas syndrome, Diamond-Blackfan syndrome is also named as pure red cell anemia. So, as the name implies, it may start with anemia only, but by time, it may proceed to pancytopenia. TAR syndrome, thrombocytopenia with absent radii. There is only thrombocytopenia in those cases, no anemia or no neutropenia. Chidiac and Viscount-Aldrich are actually multi-system disorders, but they present neutropenia or thrombocytopenia, and they are immune disorders, immune deficiency disorders. And as you can see in the last column, many of these disorders are associated with malignancies, especially hematopoietic malignancies. The incidence of Fanconi's aplastic anemia is 2.5 per million live births, but the carriership is very high. 1 in 108 is carriership. It's a bit higher in adults, in males than females, usually inherited in an autosomal recessive mode. There are some forms inherited as X-linked. Clinical manifestations are heterogeneous due to variable expression and expressivity. If you have different siblings in the same family, the symptoms and the age of onset for the symptoms will be similar in those families. The diagnosis was usually made by the clinical features plus pancytopenia plus multiple congenital abnormalities. But however, there are more sensitive tests available, either genetic tests or chromosomal tests done. Congenital abnormalities, most of them are upper extremity abnormalities, and they have a special facial features. So mostly upper limbs are affected. In the body, they have short stature, small size, they are usually underweight. Cafe or lace spots as the skin symptoms are very common in those patients. So if you see a patient with pallor, short stature, typical facies, with cafe or lace spots, maybe some extremity abnormalities, you can say this may be a case of aplastic Fanconi's aplastic anemia. You can be almost sure of the diagnosis, especially if you see a few patients. Other organs are also affected. Skeletal abnormalities are common, but other organs, including eyes, ears, kidneys, are also may be affected in a lower percentage of patients. So these are cafe au lait spots. Here it is on the back of the patient and the armpit of the patient, cafe au lait spots. Another patient with cafe au lait spots. Very typical faces of the patients. Usually they have a short stature, microcephaly, epicondral folds, and the faces look similar in almost all patients. Skeletal abnormalities, I have told you. There may be thumb abnormalities, supernumerary thumbs or supernumerary fingers, which can also be seen in the radiographs. Again, here supernumerary thumbs in that patient. Chromosomal abnormalities, these cells or the chromosomes of these patients are prone to chemical abnormalities. So there is an instability in the chromosomes, in the genetic structure of those patients, which results in aplastic anemia. As for hematological manifestations, bone marrow failure is progressive. That means it usually starts with single cytopenia, either anemia or thrombocytopenia, and it may progress to pancytopenia. Hemoglobin F is usually elevated due to stress hematopoiesis, and similarly alpha-fetoprotein is elevated in those patients. Of course, since there is a problem with production of cells in the bone marrow, the bone marrow is not functioning well, but there is an impetus, the bone marrow is stimulated by the erythropoietin, so erythropoietin levels you can expect to be increased, but it doesn't help. So increase in erythropoietin doesn't help the bone marrow to produce enough number of mature hematopoietin, mature blood cells. Usually, the first hematological findings are seen around the age of 7, but it may be early, but usually this is the median age. As I have told you, these cells are sensitive to some chemical agents. So when you treat the white cells or lymphocytes of these patients with agents of deoxybutane or mitomycin C, there will be increased chromosomal breakages when you look at the karyotype of these children or patients. So there is chromosomal instability, which is related to the underlying genetic defect. Yes, we have also genetic testing for those patients. We have FANC genes, so we have genetic testing. There are at least 16 genetic subtypes, which we call the complementation groups. So each of them is related to a distinctive disease gene. So although we call it Fanconi's aplastic anemia, there are 16 different genetic arrangements. So these are all different from each other from this way or that way. So the function of these genes is DNA repair. So when there is a dysfunction of these genes, the DNA repair pathway is deranged, so DNA repair cannot be done appropriately. So this gives to an error-prone production of the red cells, which gives rise to underproduction of the red cells, instability of the blood cells, and ultimately leads to cell death. So this is the actual reason for aplasia of the bone marrow for these patients. For differential diagnosis of Fanconi's aplastic anemia, you should consider the other inherited bone marrow failure syndromes such as dyskeratosis congenita, Schwachman-Diamond syndrome, Wiskott-Aldrich, TAR syndrome. With TAR syndrome, for example, differentiation is quite easy because radius can be affected in Fanconi's aplastic anemia, but if it is affected, thumbs are not affected. However, in TAR syndrome, radius is absent and thumbs are always present. So this is a converse situation. So in Fanconi's aplastic anemia, absence of radius or involvement of the radius is always associated with some problems in the thumbs. Thumbs are affected, they are always abnormal, but in TAR syndrome, thumbs are not affected. So this is the difference. So how shall we differentiate? Well, with the clinical findings, with the physical abnormalities, and DEP, deoxybutane or mitomycin tests on the cultured lymphocytes for the karyotyping, and also with the Fanconi gene analysis. Right. This is
what I wanted to talk about today.
For aplastic anemia. Any questions?
Yes.